on the condition for that person. And we'll talk a little bit about some of the data on that. You could also decrease the severity of the acute retroviral syndrome. We saw that in our patient. Very rapidly after starting therapy, his symptoms went away. You might be able to lower that viral set point. There were a number of set point studies that have been done where they treated patients very early for 24 or 48 weeks as opposed to deferring treatment. And then they, after a period of time, they stopped the antiviral therapy, and they looked at differences between those persons who didn't get early treatment versus those who got early treatment then interrupted treatment. And they found that those that got early treatment, there was a longer period of time before they met criteria to start therapy. This was in the days when we used to use CD4 counts to show when to start treatment. So if they hit 350 T cells, you'd put them on therapy. By treating them during this period of time early on, you were able to, in a number of studies, defer the time where they needed treatment. So they determined that that was a resetting of that viral set point to a lower level. That's not something we generally do in practice, but it was an interesting finding that a number of studies had shown that. As we talked about decreasing the size of this reservoir, this residual virus, a lot of the recent studies and the major international conferences are focusing on curing HIV. The first thing is, if you can make this reservoir size small as possible, the patient could be a candidate when eventually these cure strategies are developed. And we can decrease the rate of mutation, which is an important issue. So once the virus gets established in the body, it mutates. It's constantly responding to what the immune system is throwing at it, and it creates a very broad and diverse population of virus. That gives it an incredible ability to react to whatever drug therapy we can give, whatever the immune system has to get at it. If you can interrupt that process early and have a much narrower population of virus, there's less ability for that swarm of virus to be able to break through treatment or to break through vaccination or whatever we come up with in the future. So this is a theoretical reason to start treatment early. And of course, we could reduce the risk of viral transmission during this phase when persons are most likely to be contagious. What are the disadvantages? There's always a two-sided coin. Well, you have to now have somebody on treatment for a much longer period of time, and we don't really know what the long-term clinical benefit is. Someone's going to have to start treatment at the exact moment when they're learning that they have acute HIV. It's a very traumatic time. They may not even have appropriate insurance coverage during this time. Drug toxicity, development of drug resistance. You're going to have somebody on treatment a lot longer, and they may not be ready. And then there could be adverse effects on quality of life, etc. And then it's 2013. What about cost? I don't think anybody, if anyone's here from managed care, they probably object and say, I don't want to pay for that. But we do have to think about cost in this day and age. So that is something that may have to come into these algorithms. But as I'll show you, the data is sort of growing for this intervention, and I think we could clearly recommend it. So there have been a couple of major studies looking at prevention of transmission from an HIV-infected person to their partner. If you treat the infected person, so this is the Partners for Protection study, you can reduce transmission by 92%. There's the HPTN 052 study, which showed a 96% reduction. So treatment is prevention, bring the viral load down, and protect the partners from infection. So I'm just going to close in the last few minutes talking about our new role of understanding of HIV pathogenesis and what's happening within those first couple of weeks of the infection that really sets the stage for what's going to happen to that individual for the rest of the time, the rest of their lives, really. So we understand that there's a condition called immune activation. So the model of HIV pathogenesis is not as simple as maybe we once thought. HIV gets in, kills T cells, leads to AIDS. We know that that's not really the case. Based on some studies called the SMART trial, where we see that people with HIV develop cardiovascular disease, kidney disease, dementia, liver disease, long before they develop AIDS. So something's happening from the very early stage of the infection, and we recognize from the mid-90s that the virus is growing immediately from the first day of infection. During that clinical latency that could be up to 10 years, the virus is active during that whole time. And so now we know that what's happening during that phase is HIV is infecting CD4 cells, and it's depleting their number, and it leads to an imbalance of the immune system, and this creates a state of immune activation. So we're going to go through this. And during that state of immune activation, that means the immune system is constantly in a state of irritation. Cells are being activated. Activated cells are more receptive to HIV infection, and when they're activated, they burst with a larger number of HIV. So keeping the immune system in an activated state is good for the business, for the virus. More virus is readily infected, cells are infected, and they produce more virus. So right away, that's an important factor. But in addition, most of the CD4 cells that are killed during HIV aren't even directly infected. They're killed by collateral damage. You have all these cells spewing out cytokines, toxic cytokines, and they activate neighboring cells. And once you activate a cell, it has to undergo apoptosis. It just can't be sitting there spewing out cytokines. Those cells, once they're activated, they die. So this is a lot of collateral damage that occurs. The gut is the battleground. So during acute HIV infection, where did the CD4 cell depletion mostly occur? So during the blood, you get a drop in T cells, as we saw in the beginning, and then they rebound when the viral load goes to set point. Same thing in the mesenteric lymph nodes, inguinal lymph nodes, very similar to the blood. But in the jejunum, in the small bowel, you lose the T cells, but they don't come back up again. And if you look at what happens there, most of the lymphocytes, the CD4 cells, the memory cells in the body, 60% of them live in the gut-associated lymphoid tissue. So HIV, during the initial viremia, after that first week or so, it goes to town. It hones in on the gut-associated lymphoid tissue, the lamina propria, the Peyer's patches. And there's a huge die-off, a killing of CD4 cells during these first few weeks. And there's very little CD4 response to this HIV infection. Newly recruited lymphocytes come in, they're activated, they're infected. The predator becomes the prey. And when you look at this depletion of cells, even after years of antiviral therapy, the cells don't seem to reconstitute. So you end up with this destruction of a very important lymphoid tissue, which is in the gut. So you can see this in these pictures. On the left, an HIV uninfected person, these T cells are stained by this yellow or brown dye. It's a very rich environment. On the right, during acute HIV, vroom, these cells are wiped out, as well as T cells, dendritic cells, macrophages. In this cartoon, on the left is the uninfected state in the gut. So here is the bagel and the muffin you had this morning. It's floating around in the lumen. And here is the nice endothelial lining. And in this rich milieu of lymphocytes, everything you eat gets passed through this barrier. It's like the airport security of the body. It can't get into the body unless it passes through this. HIV, all of this protective barrier is gone, or most of it. The cells are very much disrupted. You have this loss of T cells, loss of tight junctions, enterocyte apoptosis. You get leakage of gut material and what we call microbial translocation. So you measure lipopolysaccharide, which is derived from bacterial cell walls, in high levels in the bloodstream of people with HIV. So what this does is it creates a state of immune activation. These bacterial products are constantly keeping the virus activated. Our patient who had acute HIV infection, he actually did undergo an endoscopy and had a biopsy, and there was apoptosis of cells, cryptitis, lots of damage to his endothelial lining during that time. The problem is, how do you intervene, and where do you intervene in this process to stop this before it becomes irreversible? And so you can envision a scenario when this damage occurs, then you can suppress the virus with antiviral therapy. The virus goes to undetectable. But once this leaky gut syndrome develops, even if the virus is suppressed now, these lipopolysaccharide and the androgens can still persist. That maintains the state of immune activation, and you never can fully recover the immune system. So we'll see patients, undetectable viral load, but their CD4 cells just can't go up. Okay? So this is the state, this model that we're talking about: inflammation, immune activation, this microbiome, disease progression, early age, and comorbidities. HIV starts it off, immune activation, gut damage, microbial translocation. Then even if you take HIV out, this process will continue, eventually leads to imbalance of the immune system. There were a couple of very interesting studies about very early intervention during the phase where antigen is positive, but only viral load is positive. And if you intervene with antiviral therapy very early, you can shrink the size of this reservoir, and over time, it actually goes down. There was a study called Visconti where they treated patients within the first 6 months, and a number of them stopped therapy after a couple of years, and they maintained very low or undetectable viral load for 2 years. So that was only about 15% though, so we can't recommend it for everyone. So early intervention might make a difference. This is the last point. What does antiviral therapy do? So in black is a baseline. On heart, what happens to these central memory cells in the gut, in the Peyer's patches? So an HIV negative person, they have good CD4 cells, and that's maintained. If you treat during the early phase, you have a drop in these CD4 memory cells, but you can rebound. Established infection early on, or later with AIDS, you have much lower numbers, but you don't rebound on treatment. So there may be an opportunity to intervene early enough that you could reconstitute that immune system. Where that is or how early it is, we don't know. But on the front lines, you have the opportunity to offer this to a person so that eventually they may be able to benefit from these very early interventions, okay? All right, so think about it. Screen everybody. Don't even think about it. Just screen everybody. And then you're going to pick up some of these cases. Okay.
Thank you very much.